3 participants now, so that's good enough to start. There were no email questions yesterday, so I guess we were clearer than we thought we would be. Again, we'll have the chat box going. If you have any questions, feel free to send them in. We'll try to go a little bit slower today because we realize this format is a little bit difficult. And what we're going to do is I'll introduce James Collins, who's another one of our Ts. He's going to give a 25 to 30-minute talk about non-invasive ventilatory support, so you get an idea about what BiPAP is. After that, we're going to give you a brief demonstrator on a real ventilator. We didn't have that yesterday. Then we're going to go through the cases in the skill stations from the FCCS for non-invasive ventilatory support. We have a BiPAP machine here, so we'll actually put an actress playing a 68-year-old female with COPD on BiPAP. All right, if everyone could mute themselves, just because we're getting a little bit of noise. So again, if you have any questions, use the chat box. All right, so we're going to start. So we'll start with James. Go ahead. What do you?
Oh, you don't want to do. Okay.
So,
Okay, good. Hi, everybody. So I'm going to quickly go through a little bit of the theory behind BiPAP. Not much, just a bit of theory. Then what I'm going to do is I'm going to, like Dr. Melanso said, I'm going to actually take the BiPAP, go through it with you. What modes we usually pick on the BiPAP, what type of mask we usually use for the patient, how to size the mask, and then we're going to put the BiPAP on Chantal over here. In an ideal world, like in previous years, you guys would actually try the BiPAP. We would actually put it on you, and you'd feel what the patients feel. But yeah, as you can see, that's not a reality nowadays. I'm sure if we were all going to need a room together sucking on a BiPAP, we would need the Jonathan Morial cover or something if we did that nowadays. Okay, so I'll start off. So just quickly, the type of diseases that work extremely well or that work well with BiPAP when they come into emergency or in ICU for that matter. So a congestive heart failure is an ideal candidate for BiPAP. Oh, yeah, sorry. So congestive heart failure is an ideal candidate for BiPAP. A COPD exacerbation is usually the type of patients that we put on BiPAP. Any kind of pulmonary edema, really, we're going to try BiPAP. If a patient has a heavy work of breathing and they're using accessory muscles to breathe, we could try BiPAP, high respiratory rate. If they're in hypercapnic respiratory failure, so their CO2 is elevated, we will put them on BiPAP as well. And I will talk about parameters on the BiPAP that we select or what we're going to play with to try to get rid of more CO2. If a patient is in hypoxemic respiratory failure as well, so we're having a hard time maintaining a saturation, we could put them on BiPAP. If they're on a high level of oxygen, so you come in the room and they're on a non-rebreather mask, or they're on a mask where we're giving almost like 80 to 90% oxygen, and they're barely maintaining their sat with that, this is a patient that we would put on the BiPAP or consider putting on the BiPAP. One of the number one things though, when you put somebody on BiPAP, they have to be cooperative. If your patient is uncooperative, they're thrashing, they're trying to rip the mask off, it isn't going to work. You could try your best to communicate with them and calm them down. You could be the BiPAP whisperer. But in the end, if they're not cooperating, you're not going to be able to get them on the BiPAP usually. It's very difficult to do so. Okay.
every once in a while, I just jump in and summarize from a medical point of view. So the ideal patients for BiPAP are someone with acute pulmonary edema or a COPD exacerbation. In those situations, there's a solid evidence base that putting them on BiPAP as opposed to intubating leads to an improved mortality and an improved morbidity. So again, BiPAP is not inferior to endotracheal intubation in those situations. It's superior to it. Those two situations have in common is that they are diseases that are generally easily reversible within 6, 12, 18, 24 hours. In other words, it's not like an ARDS where you're expecting the patient to be ventilator dependent for weeks and weeks. And everything that James told you about in terms of the contraindications are important. But my approach would be, if you have somebody with a severe COPD exacerbation or CHF, BiPAP should be your go-to measure unless you're being limited by some of the contraindications itself. He also talked about using BiPAP with somebody with severe hypoxemic respiratory failure. You might use it in order to pre-oxygenate the patient well in order to safely intubate them. That would be another indication for BiPAP. Those are the key points I think that you need to know about indications and contraindications to BiPAP.
Okay, so just to go over some of the contraindications just quick before we actually talk about the machine. So obviously your patient has to be breathing if they go on BiPAP. They have to have some sort of spontaneous effort while they breathe. If they're unconscious and they cannot protect their airway, we don't put them on BiPAP. We tend to intubate those patients. Once again, I mentioned uncooperative patient. That's really something that we can try to communicate with them as best we could. But if they're thrashing and they're ripping off the mask, we usually can't get the BiPAP on those patients. Also, facial deformities, because it is a mask, right, that we're putting on. You're going to see when I put it on Chantal over here. It is a mask. So any patient who has trauma to the face or facial deformities or lacerations or whatever on the face, you cannot put the mask on top of that. Secretions is an iffy one. So a patient with a lot of secretions, they usually tend to end up potentially getting intubated, these patients, because of all the secretions. But we do try them on BiPAP sometimes, or at least try to buy time on the BiPAP, and we put them on. But remember, it's a mask, right, guys? So it's not a tube, it's not an airway where we can go down and suction. The secretions are there, and it could be troublesome when you put somebody on a BiPAP if they have a lot of secretions. Okay, let's start the machine now. I'm going to bring it over here. So this is one of our BiPAPs we have here, and this is what you're going to see in the unit. This is one of our brand new ones. So just quickly a little bit about the machine. So like most ventilators, no, it's okay. Yeah. So like most ventilators, it has a 50 PSI oxygen source. So, so it has an oxygen tubing that you hook into the wall, and this is what gives your machine oxygen, okay? Over here, this is where it gets room air from, all right? It's a blower that takes ambient air and it mixes so that you can dial in an oxygen. You can give anywhere between 21% to 100% oxygen. And this is where it takes the air from the room to be able to do it. There is obviously an electricity, so it's powered by an electrical plug. If this gets disconnected, all machines always have a battery that will run the machine, usually anywhere between an hour to 3 hour battery life. So if ever the machine gets disconnected, it does have a battery. The on button is very important. It's probably the most important button to know on the machines. So usually at the front of the machine or at the back of the machine. I brought two machines here. I hope everyone can hear me. Okay, good. I brought two machines because I want you guys to be aware about something. All right. Some of the BiPAPs have what we call a dual limb circuit. All right. So what there is there's two sides to the circuit. So this is what's going to hook up to your. I can sit down. That's good, actually. Good. So this is what's going to hook up to your BiPAP mask. Okay. Now you have an inspiratory side and you have an expiratory side of the circuit. So air goes in through one side of the circuit, and then you exhale through the other side. Okay. Now, on the other machine, I'll bring it over here, you only have one side of the circuit. So if you look here, there's only one circuit, all right? There's only one side. So air comes to the patient, it's hooked up to the mask. Now the question comes, how do they exhale, right? So there's two ways you can exhale. Either the mask itself has ports on it that the patient could exhale from. So I have an example of it over here. So if you look here on the mask, there's little holes right up here. These are vents that the patient will exhale from the mask. So it's hooked up to your circuit. Hooked up to your circuit like so. And they exhale on the mask. So you don't need an expiratory side of the circuit because it's right there on the mask. The other place that they can also exhale from is we have a valve here. Okay, it's an expiratory port, and the patient exhales through here. All right. So just a quick recap: if you have the dual limb circuit, your patient inspires through one side and exhales through the other. So you don't need any kind of vented mask. It doesn't matter because they inspire through here and they exhale through here. If they have a single limb circuit, all right, they either exhale through the port or they exhale on the actual mask. Now, the reason why I'm emphasizing this is because we do run into situations sometimes where we put somebody on a single limb circuit. Okay, very rare that this happens, but it has happened. We put somebody on a single limb circuit and they forget to put in the expiratory valve, and they also forget and they put a mask without vents. So a patient is basically just rebreathing their CO2, and they just rebreathe their CO2, and then we get back the gas and go, oh my God, their CO2 didn't go down, it's going up. Let's intubate. And really, the only reason why is because we just didn't make a way for the patient to exhale. So it is important to know that one of the questions you should ask when putting somebody on BiPAP, a good question to ask is, how is this patient exhaling right now? Is the valve there? And then just to make sure there is a port for exhalation. Because nowadays, the circuit you will see most of the time is the single limb circuit, the one without an expiratory side, just one circuit. So there has to be a way for the patient to exhale. All right, good. Good. I'll talk a little bit about the COVID. Do I talk a bit? Okay. So BiPAP is a highly aerosolized generating procedure. So there's a lot of aerosol that gets produced in the room when you put somebody on BiPAP. So for someone who's COVID positive, we try not to get them on BiPAP. We try our best not to put them on BiPAP. But if we do have to put them on BiPAP, if we do have to put them on BiPAP, if we do have to put somebody on BiPAP, we have to make sure that we hook a filter to where they're exhaling. Okay, this is an N100 filter, it's called. It blocks everything that when they exhale. So it's very important that we put a filter to filter anything that the patient is exhaling into the room air. It gets brought through this filter. So it is important. Another thing that we do, and Chantal just went to grab one, is we put a patient in a bubble. We make them the bubble boy. We put them around, we put them in a giant plastic bubble to avoid as much aerosolization in the room as possible. When she comes back, I'll show you guys what it looks like. But in the end, we really try not to put the patient on BiPAP, but if we need to, we will, like I said, make sure there's a filter that blocks them, and also make sure that, and we also want to make sure that
the patients we tend to use put on BiPAP in COVID times because anybody with a new diagnosis of COVID is not going on BiPAP. But if you have somebody who's got chronic COPD, who is on home BiPAP, and they happen to be COVID positive, but we think that the primary issue is the exacerbation of COPD, then we'll use BiPAP with this sort of protection. So basically they're in a bubble, And therefore, the nurses, the RTs, the orderlies who are going in the room are more protected.
And there you go. So we have them in a hood, like a plastic bubble, and we put the BiPAP right underneath them. That's what we do. And you have to make sure you filter as much as possible. Okay, good. All right, moving on.
But the general rule is for newly diagnosed COVID patients, BiPAP is avoided. Remove the intubation.
Okay, we're gonna go on Chantal's phone now because I'm gonna go on the screen.
Okay.
So we're just gonna switch screens here, and we're gonna go a bit mobile, and I'm gonna show you the screen of the BiPAP. That's what you understand what mode we're picking. All right, good. Yeah, no problem. So just to give you a starter, so the voice is gonna go on here, right?
No, I needed
okay.
it just because this is a better.
Okay, perfect. So right underneath me is
one
the
sec.
screen that we have.
You can switch it. Just let's mute this time.
Oh, we don't have to. We could use that one as the voice.
If we use it's so that
One sec. Okay.
Okay, so there's really two modes that we can pick from when deciding BiPAP, or two modes that you guys really need to know. One is called ST mode. A bit of an echo. Okay, sorry guys, I'm just gonna get the sound fixed here.
Keep going.
Oh, that's mute, so I am muted.
That's the audio. Can hear.
Sorry, guys, 2 seconds.
There we go. Okay.
So the two modes that you really need to know on the BiPAP is there's something called ST mode and there's something called CPAP. ST mode, we don't call it BiPAP. That's what when we say the word BiPAP, we're talking about this one particular mode on the ventilator. Okay. But if you look at here, it'll show up on the screen as ST mode over here. And then there's CPAP right there, and there's ST mode here. And ST mode, like I said, is BiPAP. I'm going to talk about it right now. So if you look at it, a bunch of buttons come up. Another mode that you really can compare ST mode to is very similar to, and you guys learned this yesterday with Chantal, it's pressure support. It's basically pressure support on non-invasive mechanical ventilation. So the patient breathes on their own. Okay, I'm going to show you an example. We get it up here.
If you hold it, I will get you this one.
So the patient breathes on their own. Okay. Yeah. So, and what we do is we support them with a bit of pressure every time they breathe. So we control that pressure. I'm going to show you guys here in a sec. We're going to go get a test line here so that we could. But every time they breathe in, they get a certain amount of pressure, which we control to assist their breathing and to help them. But if we had to say that this is pressure support, it's very similar. There is a rate here, if you notice over here, there is. But if we is a respiratory rate, but that rate is really just a backup rate. Okay. Yeah.
Ask for a minute. Ask when the sound is clear right now.
Adol, do you hear us? Do you hear us?
Well, the sound is not clear because I think it's better to use the other mic.
Got a microphone on.
Yeah, and I think just
Yeah. So let me move this one.
so you can bring the other mic just near to the machine, and with the multiple screen we can see the picture.
All right, testing one. Do you guys hear me better now?
Yeah.
Okay, good, awesome. I'll restart what I said, so don't worry about it.
and do you still see the ventilator screen though?
Well, everybody should be notified that they have to change the screen to multiple screens so they can see the screen.
Tell them to repeat that.
Say that again, Adol. Just say it again.
Yeah, everybody should change their screen just from the James screen to multiple screens so they can see the Chantal screen also.
Okay. All right, thank you.
Thank you.
Working through these technical difficulties.
Okay, so what I was saying, I'll do this thing.
Yeah.
So what I was saying is that there's two modes of ventilation that you really need to know about on the BiPAP. One being CPAP and one being ST mode, okay? Now ST mode, that's what the company calls it, but we call it BiPAP. When you guys are gonna order BiPAP, you're gonna sit there and say, okay, we're gonna put this patient on BiPAP. This is what you're talking about. You're talking about this particular mode. And something to compare BiPAP to, if I select it, something to compare BiPAP to is pressure support, like Chantal talked to you guys yesterday about. It's a mode where a patient breathes spontaneously, okay, and we support each breath with a pressure, all right? So if you look here, for example, I'm gonna start it up. So we're gonna hook it on this lung here. So if you look over here, down here, I have something called an IPAP. It gets a bit confusing because we have an IPAP, EPAP on the BiPAP. So I'll explain what all this is. So your IPAP is your inspiratory positive airway pressure, okay? This is what's gonna control how much inspiratory pressure I get when the patient breathes. So for example, if I set an inspiratory pressure of an IPAP of 20 and I have a PEEP of 5, well, now my pressure support is 15, all right? If I set a IPAP of 25, now I have a pressure support of 20, okay? So IPAP basically controls my inspiratory pressure, or how much my patient gets on inspiration. Now there is also an EPAP. EPAP is basically your PEEP level. Okay, it's your positive end expiratory pressure. Instead, it's EPAP, which stands for expiratory positive airway pressure. So you do have an EPAP, which is your PEEP. So your IPAP controls your inspiration, and your EPAP is basically your PEEP level, or on exhalation. So when you see that a patient doesn't have enough volume in their lungs, or you're looking at the machine up here, and you say, oh, this patient doesn't have enough tidal volume, well, you go up on your IPAP usually. So we would select our IPAP and we would increase it. We try not to go too high on IPAP because don't forget it is a mask, right? So some of it's going to go in some of this air is going to go in the stomach as well. So we try not to go on too high on our pressures when we're giving this mode. There is I did mention before, but I don't think you guys heard me, but there is a rate here, a respiratory rate that we do set, but that's not really a set respiratory rate. It's more of a backup. Okay, it's more of a backup rate. The patient spontaneously breathes in this mode. They decide their own rate. If they want to breathe at 25, they're breathing at 25, right? So this is more of a backup rate in case they go apnea, and that's why that's there. Okay, good. The other mode that I want to talk to you about is CPAP, something that we don't tend to set as much in our ICU. We tend to prefer BiPAP, and there's a reason for that. So when CPAP is a mode, it's just a PEEP. It stands for continuous positive airway pressure. It's just a PEEP level. So if I activate this, so just to show you guys, just to go back 2 seconds. So if you look at the waveforms here on BiPAP, you have when someone breathes, you have air that goes in and out, okay? So when someone breathes, you have air that goes in and out of the breath. Okay, when I go on CPAP now, remember CPAP is just a pressure. Okay,
James, maybe
yeah.
you just want to explain what each one of those waveforms
Yeah,
means.
sure, no problem. So just to quickly go over what they all mean. So you have 3 waveforms here. Okay, one of the waveforms is pressure, so it's measuring the pressure in the lungs. So you have an inspiratory side and an exhalation side. It's actually color coded if you look at the breath. It's orange on inspiration and blue on exhalation. So you see that there. The next waveform
Versus time, right?
versus time. Sorry, yes. So it's pressure over time. Okay. So it's an inspiratory. It's a pressure over time. So P versus time. The second waveform here next one is a flow waveform. That's where measuring flow. Once again, color coded. So orange is inspiration, and then exhalation is blue. All right, and once again, it's a flow over a time. And the last waveform here is a volume waveform, how much volume the patient is getting in his lungs. Once again, same thing, color coded. Orange is inspiration, and blue is exhalation. And it's also over time. All three of these waveforms are over time. Anytime you're going to see a waveform, it's usually over time. So it's pressure over time, flow over time, and volume over time. But anyways, just to say what we were talking about before. So as when I'm on ST mode or I'm on BiPAP, when a patient breathes, he gets a support. Look at the pressure waveform. He's getting a support with each breath. Okay. So he's getting, right now he's getting a pretty heavy support. He's getting a support of 20, which is high for a BiPAP. Then if we go on CPAP now, I'm just going to go up a bit on this one. Remember, CPAP is just continuous. So look now, when he breathes, he's breathing spontaneously. There's no support with each breath. There's just an elevated PEEP level, right? But he's not, look at the pressure here. He's just breathing spontaneously with a PEEP. That's it. Every time I'm taking a breath in, a bit hard to see because I can really pull back. But every time he takes a breath in, there's no support that comes with it. He's just breathing spontaneously without any support with just a PEEP. That's all he's getting. We tend to use this mode more. I mean, we prefer BiPAP because our patients usually have a really high increased work of breathing. They're hypercapnic. So we tend to prefer to put them on BiPAP. So we don't tend to use CPAP as much. CPAP would only really be used if it's an oxygenation problem. And that's why we would place the patient on CPAP.
What CPAP does is it opens up collapsed alveoli and decreases shunt. So it improves oxygenation itself. It doesn't really decrease work of breathing, except that it does improve lung compliance a little bit, so that will decrease your work of breathing. If you need an inspiratory assist, if you're really struggling to breathe, then that IPAP that you give, that increased pressure during inspiration, that's the inspiratory assist that you get with BiPAP that you don't get with CPAP. And again, if you're looking at the waveforms in terms of BiPAP, you see that what happens is the ventilator is triggered by the patient, usually. Then gas flow starts going into the patient. The gas flow is adjusted to maintain the pressure at whatever set pressure you have, 10 or 15, over the course of the breath. And then the breath is terminated at the end as the flow drops.
So there's a question here, can you control tidal volume on these machines, or can you only increase the tidal volume by increasing pressure support?
That's a really good question, Youssef. So there is some machines out there. It's rare because usually most non-invasive
Just say
mechanical.
no, just say no.
No. So most of our machines that we all have out there, it's just pressure. We control pressure. And the only way you can control tidal volume is by increasing the delta pressure, increasing the support, like Dr. Molasso just mentioned, by increasing your IPAP. That's the only way that really you could do it.
So when you have a pressure-targeted mode of ventilation, like pressure support, like BiPAP, like pressure control, volume is going to be the dependent variable. Volume is going to depend on how much pressure is going in, but it's also going to depend on the resistance and the compliance of the patient itself and how much effort the patient is contributing to the whole thing. So the volumes will vary from breath to breath, which is why assist control, volume assist control, is a more reliable form of ventilation when you have an intubated patient. If you're in an area where you have suboptimal monitoring, like the emergency department, there you're going to get a defined 500 cc's of volume with every single breath unless you pressure alarm. But with any sort of pressure targeted mode of ventilation, you have to keep examining the patient and you have to be looking to see what the volumes are because they're going to be variable.
Perfect. So just to cue in on what they just said, if you look here, for example, so I have an IPAP set at 10 and I have an EPAP set at 5. So my pressure I'm giving right now is 5. But if you look up at the volume up here, bring it up here sometime. If you look up at the tidal volume here, I'm only getting 152 milliliters, right? So if I increase that IPAP right now, I increase that inspiratory positive airway pressure. I'm going to just go up. If you look at your volume now, it starts to rise as I'm giving more pressure in my lungs. Right now I'm at 474, 556. So the more inspiratory positive airway pressure I give, the more IPAP I give, the better my total volume should be. And the less I give, the lower my total volume should be. Yeah. Unless the patient's effort, of course.
And when you're initiating BiPAP on somebody, you generally start off with an IPAP of 10, but then you're looking at the patient and you're adjusting it up or down until you get the target tidal volume and the target respiratory rate that you're comfortable with. So let's say you want 400 to 500 cc's and you want the patient breathing less than 30 per minute. So there is a little bit of titration that's required over the first 15, 20, 30 minutes at least, and sometimes longer.
Perfect. Okay, so I'm going to show you guys about how we put it on somebody now. So Chantal's going to come here.
So we can go back.
Yeah, we can go back to the other screen now. We're going to go back to the other, we're going to, so.
Okay, let me get, do the camera work.
I know, it kind of gets, you want to
But
sit,
it's
maybe?
okay.
No, that's okay,
it
I
should
sit
go-
on here.
Okay. So to talk about the mask for a second, okay? Sizing of the mask is very important in BiPAP. You don't want the mask to be too large. You don't want the mask to be too small. A mask should fit on the bridge, in the middle of the bridge of the nose over here, and go right in the middle of the chin over here. That's how big the mask should be. You don't want a mask to be too big because you don't want it going into the patient's eyes. So you don't want a mask up here sitting in the patient's eyes. And you don't want the mask to go where below where the patient's chin is. So what you really want is to go right in the bridge, in the middle of the bridge of the nose to the middle of the chin over here. That's where you want the BiPAP mask to sit. But when you have larger masks on a patient's face, it could create more leaks. And you could run into trouble because your BiPAP is just leaking way too much. So when I hook it onto my patient, all right, communication is key, all right? It's all about communication. You don't just come up and shove it on the patient's face like that, all right? You don't do that, right? That's not good. Exactly, you're gonna get that reaction. You're gonna get punched in the face. You don't wanna do that. So what you wanna do is you wanna communicate. Hi, ma'am.
Hello.
I'm going to be putting you on BiPAP right now, okay? You're like, what the hell is BiPAP? Okay, I'll tell you. It's a mask. It's going to push a lot of air in your lungs, okay? It's normal. It's going to feel like a lot of air, all right? Just try to breathe with the machine. I'm not going to strap it in just yet. Make sure to say that's one thing we always say. We're not going to strap it in. We're just going to feel it, put it on your face, and see how it feels, okay? I'm just going to make sure I'm not going to blow Chantal's lungs up. I'm going to bring them down. And also important is, like Dr. Mosso said, you want to start with at least a pressure support of 10. You don't want to start with 20 off the bat. That's way too much pressure. The patient's not going to like it. You start with a lower pressure, that way that they could tolerate it. So, okay, here we go. We're going to put it on your, there we go. So you put it on them. Okay, breathe with the machine then. Very good. That's it. You're doing great. You have to coddle the patient. You got to communicate with them as much as you can. All right, how does that feel? Is that okay? All right, good. That's good. She's a great patient. So now we're gonna strap, after we're done, we have to strap the mask on. That's sometimes the harder part, depending on the straps that you have. Chantal's a perfect patient because she has no hair. She has a shaved head, which is perfect, because when a lot of patient has a lot of hair, it could get quite complicated. So then what we do, we go around. Okay, I'm gonna strap the mask in now. All right, you could hold it if you want. So if your patient is or they have the mobility to be able to hold their own mask, you can make them hold their own mask as well. All right, here we go. Good. And then after that, I need to tighten the mask on your machine, on your actual BiPAP. I don't know if you can see it here. There is a section that reads the leak. Okay, it reads how much is leaking around the patient's mask. So what we do is we tighten the mask or adjust the mask to be able to get a certain leak. Now, we don't want no leak. If there's zero leak, that's not good. It means the mask is way too tight on the patient's face. You do want somewhat of a leak, but you don't want too much of a leak. We usually accept on this particular machine, we accept about 20. We can accept anywhere between 20 and 60 liters per minute, depending on the machine. Obviously, if you're seeing a leak of 100 liters per minute, that is not good. That's way too high. So we range anywhere between 20 and 60 liters per minute. Like I said, a zero leak is not good either. It means that mask is just way too tight on the patient. There is going to be a leak on this machine. We just don't want too much of one. Okay, good. So we have her on ST mode right now. So she has a IPAP of 10 with an EPAP of 5 right now. So means she has a support of 5. Okay. So
Can you
we
explain what ST is?
yes,
You did?
I did. It was a BiPAP. Yeah. So remember, ST is the mode they call it on this ventilator.
But in terms of triggering the ventilator, can you explain that?
No, I did. I could. Okay, good. So another thing about ST mode stands for spontaneous time. That's what the actual mode stands for. Now remember, it's very similar to pressure support in the sense that the patient triggers the breath, the patient gets the IPAP, he gets the inspiratory pressure, and when the flow falls to a certain amount, it cycles to exhalation. Now, like I mentioned before, there is that backup rate that is in there as well. If the patient doesn't breathe above 12 breaths per minute, so for example, I have a rate set at 10. Let's say I set it at 10. Okay, I have my backup rate set at 10. If my patient doesn't breathe, if he starts breathing below 10, the machine will start to give breaths to bring him up to a respiratory rate of 10 breaths per minute. So that your respiratory rate basically becomes like your minimum respiratory rate. You need to breathe 10 and above. If you're breathing above, all your breaths are going to be spontaneous. They're all going to be pressure-supported breaths. If you don't breathe above 10 and you breathe below 10, then the machine will give breaths to bring you up to 10. It will give you mandatory breaths to bring you up to 10. So if you, once again, if you set 20, now the thing about the respiratory rate is we tend to keep it low on the BiPAP. The reason for this is because your patient should be spontaneously breathing when they're put on BiPAP. So we tend not to set their rate very high. We set it around 10 or 8 breaths per minute. But if you were to set it, like for example, at 20 breaths per minute, the patient would have to breathe above 20. If they don't, if they're breathing less than 20, then the machine will give mandatory breaths to boost them to 20 breaths per minute.
So in answer to Yusuf's question about hypercapnic respiratory failure, where you want to increase the ventilatory support, the only way of practically doing it on BiPAP is to increase the pressure. Pressure is the set variable, and volume, tidal volume is going to be the dependent variable. Yes, you can increase the rate, but clinically, if you're really having to increase the rate in that situation, you should be thinking about intubating the patient.
Yeah. Okay, good. That was a question. Anything?
Yeah, no,
That's it?
we're good. But, does the NG tube or OG tube cause significant leak?
Yes, it does.
Just repeat that question.
So the question is, does the NG tube or the OG tube cause it? Well, first of all, they won't have an OG in with a BiPAP mask because an OG is very uncomfortable for the patient. They're going to gag, but they might have an NG. You're right. They might have an NG. They might have a dob off. They might have these feeding tubes in there. If they do have one, it does cause leak because what happens is it comes in the side of the mask. You can't really see this here, but it comes in the side of the mask and it creates a leak. So you will have to tighten up the mask a little bit more than you usually would with the NG tube.
Usually the leak is manageable. Rarely we will remove the NG tube for a temporary period of time in order to better ventilate. But usually it's manageable.
It is manageable. You can always tighten the mask. It becomes a bit uncomfortable for the patient, but BiPAP in itself is not a very comfortable device. Patients tend to not. Some patients they do react well to it, but a lot of them sometimes it takes a lot of coaching with them, and you have to really, like I said, the communication aspect is always there. Okay, I mentioned the alarm over here. I mentioned the leaks. Remember, the machine does measure leaks. I know it's hard to see over here, but it does measure leaks, and we do adjust how tight our mask is according to those leaks. Remember, zero leak is not good. But too much leak is not good either. You want to go kind of in between. No, it's okay. It does have a large
variety of masks you have.
Yeah. That's yeah. So there is. I have two. There's a lot of masks out there. Different types of masks and different types. But I'm going to talk about the two ones you're going to see here. We have a nasal mask. So this is a mask that.
Okay.
This is a mask that fits right on top of the patient and goes on their nose. So as you can see, they're breathing, the mask, it does not cover their mouth. It's only covering their nose. Very rare you're gonna see this mask in an intensive care unit. The reason for that is because our patients who are struggling to breathe and they're working hard to breathe are usually mouth breathers, right? They're gonna breathe through their mouth. So we wanna cover both their nose and their mouth to support them. So which is why we go with the
Where you would see a nasal mask is somebody who's on chronic home ventilation with a nasal mask and are admitted to the hospital for another reason, and you may be continuing it. But you're not going to use a nasal mask for somebody with acute respiratory failure. It's going to be a full face mask.
So that's why you're going to use the full face mask, which you just saw before, that covers both their nose and their mouth. All right, because they're in respiratory, they're in distress, so they're using their mouth to breathe.
Now, the danger, the downside of a full face mask versus a nasal mask is if the patient vomits, particularly if they can't get to the mask and take it off, then they'll have a mask full of vomit and a high risk of aspiration, which is one of the reasons why full face masks are not permitted on regular wards at the MUHC.
Yeah. Okay, good. Quickly go over it, but there is alarms on a ventilator as well.
Just to have another, in terms of the vomiting, that's always a risk in somebody with a full face mask because as you're forcing air into the lungs, you can get gastric distension. So one of the things that you are, when you're following the patient on BiPAP, you're checking to make sure that they're not getting too much air in the stomach and therefore at a higher risk of vomiting and aspiration. Those risks go up as the target pressure is increased. You usually don't have that problem at a pressure score of 10. But once you're getting to 20 or above, you're getting more and more concerned about gastric distension and vomiting.
Yeah. Okay, just quickly on the machine, I'm not going to talk too much about it, but there is alarms on a ventilator that I think maybe Chantal talked about it yesterday. But so there is alarms on the ventilator that will ring. The ventilator will ring when it tells you that certain things. So for example, over here, I have a high respiratory rate. When your rate, for example, goes above 30 here, the ventilator will ring. If your rate drops too low, the ventilator will ring. There's even an alarm for a leak. This particular machine will ring when the leak goes too high to warn you that the patient, you have to tighten this mask or go check what's going on because there's quite a high leak. There's a high pressure, a low pressure. There's even a high volume and a low volume. And there's even an apnea time. So this apnea time is 20 seconds, okay? And what it does is after 20 seconds, if the patient hasn't breathed, the machine will go into backup ventilation and it'll give a backup. Yeah. All right, good. All right, just to go back on last thing I want to talk about with you guys. So I'm on ST mode right now. So I have an IPAP of, usually I'll start with an IPAP of 15 and I'll start with a PEEP of about 5 or 8. Or an EPAP, sorry, of 5 or 8. And what we'll do is we'll put it on the patient, and we'll look at that tidal volume up there, and we'll decide should I go higher or should I go lower on that IPAP, depending on what tidal volume I get. If you get a very high tidal volume, it's reading 700, 800 on the BiPAP, you could consider dropping that IPAP, dropping that inspiratory pressure, because I'm giving too much support to this patient. If you put it on the patient and you're getting a very low tidal volume, you're getting only 250 or 200 milliliters, first you should think, oh, is there leaks? Check your leaks, and if your leaks are normal, then you would consider going up on your inspiratory pressure to give more volume to your patient. Another thing too is if you get back, it's like the question, like Yusuf's question before, If you get back a blood gas and you're still hypercapnic, your pH is low and your CO2 is still elevated, I think I'm far away from that. If you decide, and if you go and you get back a blood gas and your CO2 is still elevated, you would adjust your IPAP. You'd go up and give a higher IPAP, give a higher pressure so that your tidal volume would go up and you ventilate your patient more. Like Dr. Malonzo mentioned before, we shouldn't be playing with that respiratory rate. That respiratory rate is really meant for a backup. Your patient should be breathing on their own. The only thing you can adjust to get rid of CO2 or to eliminate CO2 would be that delta pressure, would be that IPAP to control the, to get rid of CO2. Okay, I think that's what I got. Is that good? Anything else? Oh, oxygenation. Sorry, one last thing. One last thing, guys. For oxygenation, there's only two buttons really you could play with on the machine to help oxygenate the patient. One is your FiO2, so anywhere between 21 and 100% oxygen. We don't want to give too much oxygen, oxygen toxicity. So what we do is we play with our EPAP, we play with our PEEP, and we can give more EPAP and give more PEEP to help oxygenate our patients. So only FiO2 and PEEP is really the two things that you can adjust on the BiPAP to help oxygenate the patient. Just one warning, if on most BiPAPs, if I go up on my EPAP, if I go up on my PEEP, I cut into my pressure. So I have to readjust my inspiratory pressure to compensate for that. So for example, if I have an IPAP of 15 and I have an EPAP of 5, okay, I have a pressure support of 10 here, all right? So my IPAP is 15 and my EPAP is 5. I have a pressure support of 10. If I say, oh, my patient's not oxygenating well, let's go up on the EPAP. So I go up to 10, let's say, all right? I've just cut into my pressure. My pressure support is now 5. It was 10, but now because I went up on my EPAP, all right? Now because I went on my EPAP, it cut into my driving pressure. So I have to adjust that. I have to make sure to go back up on my IPAP so I can maintain the same pressure, maintain the same inspiratory pressure. Anyways, that's it. That's what I got for you guys. So I think we're gonna do some cases.
Well, I think what we'll do is, hold on. So it's 7 minutes to 1. We'll take a 7-minute break. We'll start back at 1 o'clock with the cases itself. I just want to make one more comment about IPAP, EPAP, pressure support. So a lot of the terminology for mechanical ventilation is confusing because there is no standard international agreement on term what is the correct term. And every ventilator manufacturer tries to come up with a new term that will sell their ventilator as a marketing ploy. So it's kind of like luxury cars that try to sell you that they have X drive or something like that, where basically they're all the same type of thing. So if you're confused about the terminology for mechanical ventilation, it's not you. It's medicine in general that's doing this. So one of the confusing aspects of it, although pressure support and BiPAP should be equivalent, one being with an endotracheal tube, the other one being with mask ventilation, the terminology used is slightly different. So when you're talking about BiPAP with an IPAP and an EPAP, a IPAP of 10 means that the actual inspiratory pressure, the peak pressure, is 10 centimeters of water. And an EPAP of 5 means that the expiratory pressure is 5. When we're talking about pressure support, the PEEP is the same. So a PEEP of 5 is the same as an EPAP of 5, but the pressure support component refers to the driving pressure, the difference between the expiratory pressure and the inspiratory pressure. So a pressure support of 5 and PEEP of 5 is equivalent to an IPAP of 10 and a PEEP of 5. I hope that sort of made sense. Okay, just think about, so just in terms of with the machine, the BiPAP, The actual EPAP and the IPAP are the actual pressures that you're seeing on the ventilator itself. Whereas in pressure support, you're talking about the driving pressure or the increase from the PEEP to the inspiratory pressure. So again, a BiPAP of 10/5 is equivalent to a pressure support of 5 and 5, a pressure support of 5 and a PEEP of 5. The pressure support of 5 refers to the difference between the 10 centimeters on inspiratory pressure and the 5 centimeters on expiratory pressure.
Just to answer that question real quick.
Will we be adjusting
yeah.
inspiratory time, or is that always set as 1?
So in a spontaneous mode of ventilation, whether it's pressure support on an intubated patient or on BiPAP, we don't set an inspiratory time. It's the patient who will decide of how long their breath is going to be. So we actually don't set an I time on BiPAP.
So that's called cycling off, or the termination of the breath. So on pressure control, yes, the pressure is maintained at 10 or 20 for 1 second or whatever you set it's time cycled. In other words, the pressure is kept at that time on that level until the time is up, and that time is whatever you set it at. And then it cycles off and the patient exhales. For both BiPAP and pressure support, the way the breath is stopped is the machine looks at the peak pressure, let's say the peak flow, sorry, say it's 100 liters per minute. Once that peak flow drops down to a preset threshold, it's usually 25%. So in this example, it would be 25 liters per minute. It takes that as a signal that the patient is getting ready to expire, and it cuts the gas flow in. Okay, and you can adjust that. If there's patients who want to terminate the breath a little bit earlier or a little bit later, you can adjust that and make it 30% or 20% or something like that. So pressure control or pressure assist control on the ventilator, that is time cycled or time terminated in terms of the breath. For pressure support and BiPAP, it's flow cycled, meaning once the flow drops to a certain predefined threshold, that's how the breath is terminated. Meaning that for pressure support or BiPAP, the patient has much more say in terms of the duration of the breath, and the breaths will be shorter or longer depending on how the patient breathes, as opposed to a fixed time. Okay, we'll stop there and come back. And well, let's make it at 5 after 1 now, since we took up some of the break time. Okay? We didn't mention high flow nasal cannula, or Octaflow, which has been becoming more and more prevalent in the last 5 years or so. So James is just going to give a quick demonstration of what Octaflow is.
So Chantal, you want to sit down?
Oh, yeah.
Yeah.
I'll do it.
So you can think about this as, well, you know, for nasal prongs, we usually don't go much above 6 liters per minute, because it's very irritating to the nose, it's very drying to the nose, and patients don't tolerate it very well. So that's a standard nasal cannula.
So the standard nasal cannula. You guys have all seen this probably, but this is your standard nasal cannula that we just hook up to oxygen on the wall. Like Dr. Malasso said, we can't go higher than usually 5 to 6 liters per minute, because it could dry the nasal passage, you could have bleeding, it could be irritating, it could be very uncomfortable for the patient.
Now, how much oxygen, when you have somebody with hypoxemic respiratory failure, the important thing is not how much oxygen, whether it's 100% coming out of the wall circuit or what you have hooked up with the mask. The important thing is how much oxygen is actually getting down to the patient's alveoli and the lungs. And that's going to depend on the amount of oxygen delivered by your device, and also how much room air is entrained. And there's always going to be some room air that's entrained, And if you have 100% oxygen and 50% of what's getting into the alveoli is 100% oxygen delivering and 50% is from room air entrainment, then the patient is actually only getting 50% to the alveoli that matters. So in terms of what we can do to help improve the amount of oxygen delivery, let's say that she is very dyspneic right now because she's hypoxemic and she's demanding 60 liters per minute and we're giving 5 liters per minute by the nasal cannula. That obviously means that most of what she's going to get is room air. So we can try to increase the amount of flow, and we can do this in a way that is better tolerated for the patient. So this is one humidified air. It's not the dry air that you're giving with nasal prongs, and it's warmed as well. So you can think of it like a tropical rainforest that's you're blowing up someone's nose at 60 liters per minute. Which means that, again, if she, again, is demanding, say, 80 liters per minute, and we're giving 60 liters per minute of 100% oxygen, the amount of oxygen that's getting to her alveoli, the percentage is going to be much higher than the previous example.
So it's very similar. It's a nasal prong, like you can see over here. The only difference is instead of going to 6 liters per minute with my device over here, because it's humidified, because also just mentioned, we can go up to, usually we go up to 40, 50, 60 liters per minute of flow. So it's really like breathe through a tropical rainforest, exactly, because it's quite humidified.
Kind of like a hurricane.
Exactly. You know what I mean? We can't go on vacations anymore because of COVID. This is the best you got. You got high flow. Okay. So that's basically what it is. Helps oxygenate the patient. If you're having trouble oxygenating the patient, there is an FiO2 that we adjust on the machine as well. So you can adjust an oxygen. You can go anywhere between 21 and 100% oxygen again on the actual machine. The flow we usually keep around, we usually start anywhere between 40 to 50. And if the patient requires, you see that they're working harder or whatnot, and they require more flow, we tend to go up on the flow. If they're not oxygenating well, we tend to go up on the FiO2. And that's usually what we adjust. There's only 3 things you can adjust on this machine: FiO2, flow, and temperature. And the temperature we keep it the same, 31 degrees. That's it, and it helps. It's become more popular lately because it's a lot more comfortable compared than BiPAP. But the minute the patient's hypercapnic, remember this, guys, the minute someone's CO2 is elevated, we don't put them on high flow, we will put them on BiPAP. Although the high flow nasal cannula does get rid of the dead space, it flushes out dead space, it does not eliminate CO2 as well as the BiPAP does, okay? The BiPAP is really what helps eliminate CO2. We ventilate the patient with a pressure support.
I think that one of the top 2 or 3 most significant advances in the treatment of COVID patients in the last 3 to 4 months that we've learned is a more aggressive and earlier use of high flow nasal cannula as opposed to intubation. When the COVID epidemic first started, we were very concerned about the aerosolized generating properties of high flow nasal cannula. We didn't want to put patients on BiPAP, again, because of the aerosolized generating point. So we're intubating people very early at that point in time. And we talked about the possible deleterious effects of mechanical ventilation yesterday in terms of volutrauma, barotrauma, oxygen toxicity, and there's something else called atelectrotrauma we won't get into. But the point is, the ventilator itself can induce lung injury. And we think we were getting that early in the COVID epidemic. We were injuring a lot of lungs that we may have been able to avoid intubation in general. So I'd say about a month into it, we started going much more to high flow nasal cannula very early on. We put people in negative pressure rooms with the high flow. They wear a surgical mask, so the aerosolization is diminished somewhat. There's studies out that's suggesting that as long as you're not within 2 feet of the patient and you're wearing full PPE, you're relatively safe as a healthcare worker. But what it's clearly better for the patients. There's no question about that. And a hypoxic respiratory failure secondary to COVID is an ideal situation to start high flow nasal cannula on. to an attempt to trying to avoid intubation and the deleterious effects of intubation. Okay, so James just stepped out of the room.
We can continue on with the cases.
So I'm going to, what we're going to do now is a couple cases demonstrating the use of BiPAP. So this is on your, you've all gotten the copies of the skill stations for non-invasive ventilatory support. So I'll just go through the case scenario. It's kind of a classic case. It's a 68-year-old female who's got smoking-associated severe COPD, is continuing to smoke but trying to quit, who has the typical exacerbation symptoms with a 1-week history of increasing cough, productive of yellow sputum. There's no blood in it. It's not greenish. She has, doesn't mention what her rescue plan is, but most of these patients have some sort of rescue plan where they increase their bronchodilators, maybe start steroids, and maybe start an antibiotic. She's increased her bronchodilators, but has continued to worsen. She's got a low-grade fever at 38 degrees. She's slightly tachycardic at 120, sinus. She's breathing rapidly at 32. Her blood pressure is elevated, and her room air oxygen saturation is down to 85%. Okay, and then when you examine her, she has the typical signs that you expect with somebody who's got acute bronchospasm and increased work of breathing. She's sitting forward, she's in a tripod position, she's clearly using accessory muscles, she has the nasal flaring, she has a very prolonged expiratory phase with wheezing, indicating that she has obstruction and difficulty emptying her lungs, and she's only able to answer questions with 2 to 3 words. She gets a chest x-ray that shows she's got hyperinflated lungs, but no clear infiltrate, no pulmonary edema, no pneumothorax. And she's got a room air arterial blood gas with a pH of 7.29. PCO2 is elevated at 64. So there's an acute component to this. Her room air PO2 is 57. Her saturation is 86%. She's got a bicarb that's slightly elevated that indicates that she probably has a baseline hypercapnia, CO2 retention. And her medical record reveals 8 admissions in the last 10 months for exacerbation of COPD. So she's here frequently with those issues. So again, the first way of approaching this case, you have to train yourself and try to say that this is not somebody with a COPD exacerbation. It's somebody with COPD who has increased difficulty breathing, because your first response is to rule out other things that could be more life-threatening. So the things that you'd be looking for would be pneumonia, you'd be looking for a pneumothorax. Many of these patients have coexisting coronary artery disease, so you want to make sure that she doesn't have pulmonary edema secondary to an MI. You always have to think about PE in the background. But for the most part, once you've eliminated those things, and they're reasonably, PE is almost impossible to completely eliminate in those patients, but as long as you feel the pretest probability of pulmonary embolus is low, you can set those aside and then focus on a patient with a COPD exacerbation. Okay, so when we're doing that, you know, the first response is bronchodilators, bronchodilators, bronchodilators. And you'd be aggressive and near continuous with the bronchodilators. She's a bit tachycardic right now at 118, so you may be limited in terms of your Ventolin that you can give. Although the Ventolin, if it decreases the bronchospasm, it can paradoxically decrease the heart rate. But you may be going more with Atrovent. You would be putting her on steroids, and with her history of increasing sputum, even though she's got a clear chest X-ray, you would be putting her on antibiotics as well. In the meantime, while you're waiting for the bronchospasm to get better, you are going to have to support her with ventilation. So this is where BiPAP comes into view, and this is a classic situation where BiPAP has been demonstrated to be more effective than nothing, not doing anything except the standard medical management, and more effective than intubation. So where's James? Is he?
I don't know, he was called.
Okay, so what are we going to do?
Oh, we can just continue with the cases. Something I just want to add for like patients like this who are placed on BiPAP for management. It's important that they have a close monitoring while we're trying to figure out what's the underlying cause of this exacerbation. They need to be in a monitored area and they need to be kept an eye on. So we visit these patients every 2 hours, but they do need to be in a monitored setting, so in a critical care area.
Of all of the things that are important, it's the physical exam. If you see people who are recruiting their accessory muscles, then that's more important to me than the blood gas. It's more important to me than the chest X-ray. And you have to do something to reverse that process fairly quickly. So if you see this patient on a internal medicine or a surgical floor, your first response is to give them bronchodilators, for sure. The steroids are going to take hours to start working. The antibiotics are nice, but again, you're not going to get an immediate response. You need to decrease their work of breathing fairly quickly. If after one aerosol, they're not significantly improved, then they really should be moved to a monitored setting. When we talk about 60% of the code blues in hospitals being under-recognized, the symptoms or severity of the symptoms not being recognized for 6 hours before, this is a sort of a classic case where somebody's having difficulty breathing, the severity is not appreciated very much, they're not getting as aggressive therapy as they should be getting, they're not moved to a monitored setting as early as they should have been, and then they have a primary respiratory leading to a cardiac arrest on the floor. So again, they're asking you what information is missing from this important. They're talking about advanced directives or code status. Certainly somebody who has got this degree of severity, who has been admitted multiple times in the last year, should have a up-to-date valid level of intervention discussion. Particularly aimed at intubation, because you could make an argument that this patient, if she gets intubated, a prolonged course on a ventilator may be anticipated, and that may not be concordant with everyone's wishes. The level of consciousness at the time of the exam is also going to be very, very important. If she's already obtunded because of her COPD or CO2 retention, then you're going to have to be moving more quickly to intubation. Again, it's a sign that this patient really needs to be in a monitored setting. So transfer to the ICU, within 15 minutes, not within 3 to 4 hours, as quickly as possible. They're asking how you would interpret the arterial blood gas information again. So this is pretty well a classic case of an acute hypercapnic respiratory failure. The pH is 7.29, so she's acidemic. The PCO2 is 64. Now, there's many formulas you can use to calculate how much of that is acute and how much is not, how much is chronic. But this basically eyeballing the whole situation, I would say her baseline CO2 is probably around 45 to 50. So it's increased to 64. That's why her bicarb is up around 30. So it's likely an acute on chronic situation. There clearly is an acute component to it. And again, the work of breathing, the accessory muscles used, the indrawing, the retractions, all of those are more important in terms of making decisions than the blood gas. And I'm going to be following those in terms of whether the patient is responding well to the therapy more than anything else. So we would give her, she's on the floor, you would be giving her the ventilator and Atrovent. Immediately after it's given, you will reassess her. You really shouldn't be out of the room for much more than 5 to 10 minutes in this sort of situation. And again, you're going to be looking at her level of consciousness. You're going to be looking at her respiratory rate. Sure, you're going to be listening to the lungs with your stethoscope, but the thing that you're going to be paying attention to most is her accessory muscle use and her work of breathing. As long as there's some evidence of increased work of breathing, that is a tenuous situation that needs to be aggressively reversed. And again, for COPD exacerbations, you can just think about the standard 5-pack or 6-pack that you give people. Ventolin Atrovent, you give them steroids, you give them antibiotics, positive pressure ventilation, and maybe some chest physio and help with pulmonary toilet suctioning. So that's your therapeutic options, and you're going to be trying to maximize all of those options. In this situation, she really should be placed on BiPAP as soon as possible. And the BiPAP, again, is going to be, you're using that to improve her oxygenation and decrease her work of breathing, but you're still going to be aggressively treating with the antibiotics, the steroids, but more importantly, the bronchodilators, because you're trying to reverse this process as quickly as possible and get her off the BiPAP as quickly as possible. It's not slap on BiPAP and then walk away and everything else is okay.
Exactly.
All right.
And just one last thing, this typical case, if it's a patient who needs to be on the BiPAP for a little bit longer, it's really important to offer the patient small breaks off the machine, even if, say, the CO2 still hasn't come down to what we would like it to be, and there still is some work of breathing. For patient compliance to the therapy, we offer short breaks, just, to give them a chance to be off that uncomfortable mask for 10, even if it's just 10-15 minutes, if they can tolerate it on, say, alternating with high flow or with a oxygen mask, so that then we're able to put them back on and keep them on for longer. Just for patient compliance, it's helpful to know, oh, I'm going to get a break in 2 hours. It helps.
Yeah, and some of these patients unfortunately end up with pressure sores about their nose, the bridge of their nose particularly, but on their face, because of the necessity of having a very tight face mask seal for prolonged periods of time. So those are the things that you're looking out for. So in terms of this patient, the indications for the non-invasive ventilatory support is that 1, she's got a COPD exacerbation. 2, she has increased work of breathing. That's enough for me. But her blood gas also shows an acute hypercapnic respiratory failure for that. So those are the indications for BiPAP for it. You'd also think, does she have any significant contraindications for it? And the contraindications would be, okay, a level of advanced directives that are not concordant with BiPAP, which is rare, but it can occur. 2, a decreased level of consciousness. 3, difficulty, agitation, so cooperating with BiPAP, but in this sort of situation, I would suggest I would be using sedation with ketamine or something like that. Again, it has to be done in a monitored setting in order to get her to tolerate the BiPAP first before moving on to intubation. If she has a tremendous amount of secretions, so she has a pneumonia with a lot of secretions, BiPAP is going to worsen pulmonary toilet. It's going to hold the secretions inside the lung and can potentially eventually worsen the pneumonia. It's not going to cause a problem in the first 4 to 6 hours, so it could be still used as a temporizing measure. But if you have a patient with a pneumonia and significant secretions and they need ventilatory support, then intubation is probably the better choice. And then you get the other rare contraindications, such as somebody who's got an acute upper GI bleed, somebody who's got problems with their face, facial trauma, or something like that. But for the most part, BiPAP will be the preferred therapy, and it will be tolerated. So are you going to put someone on? What are you going to do?
Want to put it on again?
Yeah,
we can do that.
Well, no, I think
No,
we
you've already done it?
just,
Okay.
yeah, we kind of integrated that into the first part.
Maybe just
So there was one more
Would it
case.
give you a blood gas, and what do you adjust on the machine?
Okay, so well, let's go through this case. So we have this
Yeah, here, I can.
68-year-old female, and this is her situation. We're giving her Ventolin and Atrovent. We started the steroids, we started the antibiotics, and now we're about to approach her with BiPAP. So then the question is, how do we adjust the BiPAP? And how do we monitor this patient over the next 30 minutes, 60 minutes, 4 hours? So I'll leave that to you two.
So, I don't know if you can see the screen. I'll try to bring it up. Hard to see, but we could. So if you get back your blood gas, so like we mentioned before, we tend to start with we tend to start with so we will start with a pressure support of 10, and we'll put the patient on that. We'll usually start with an EPAP of 5, and we'll put the patient on that. And then what we'll do is we'll monitor the tidal volume and see if they're getting a pretty decent tidal volume. We want to see at least 6 mLs per kilo, 6-7 mLs per kilogram of tidal volume. And like I said, it's measured at the top here. Usually, you'll any BiPAP you get does measure tidal volume. Once we get that decent number, if we get back a blood gas and the patient is still hypercapnic. Now remember, yesterday on a ventilator, you guys learned, oh, we could adjust the respiratory rate, or we could adjust pressure, or we can give more volume. On a BiPAP, all you really have at your disposal is to give more IPAP. So if you see that the patient is still hypercapnic and the pH is still abnormal, what you would do is you would go up on your inspiratory pressure. Usually we like to go up by an inspiratory pressure of 2 to 4 centimeters of water, but we're going to monitor our tidal volume to make sure they're getting more tidal volume. So if they're getting a tidal volume, let's say 450, then we're going to go up by, let's say, from 10 to 12 to 14. And then you would monitor their tidal volume to make sure that it is going up and that their minute ventilation is going to be going up because of that higher tidal volume.
And something to keep in mind is that this is not an invasive device. We have to go through the upper airway when we're ventilating with the BiPAP. Mm-hmm. So sometimes we can be limited where we're going up with the IPAP and we have no improvement necessarily in our tidal volume. And yes, if we increase the EPAP, because say there's upper airway obstruction, then we open up the airway and then we're able to ventilate more. So the first reflex will be, yes, to increase our IPAP, but keep in mind, we could also use the EPAP in our favor to avoid some upper airway obstruction.
But you would also be giving an additional dose of bronchodilators at this point in time. Remember, this is really a bridge or a temporizing device where you're trying to reverse the underlying physiologic process, and bronchodilators should never be forgotten. Yeah.
And don't forget, the more IPAP you give, the more leak you're going to have on your ventilator. So something to always keep an eye on as well is you're going to have more of a leak.
So you mentioned how you're going to be, approaching the patient with a face mask, starting the EPAP and the IPAP, and looking at the patient's respiratory rate, the tidal volume, and the work of breathing. That's basically what you're monitoring, right?
Yeah.
And yes, you'll be watching the heart rate. You'd hope the heart rate is coming down. You'd be hoping the respiratory rate is coming down, the blood pressure is coming down, and the patient looks better and will tell you that they're breathing easier. Those are going to be your primary ways of monitoring the patient over the next little while. Now, what's your approach to this patient? Also had a room air saturation of 85–86% and a room air PO2 of 55%. So what's your approach to the oxygenation of this patient? Remember, we're thinking that ventilation and oxygenation are almost independent processes for the lungs. We've been dealing with the ventilatory component. What are we going to do about the oxygenation component now?
All right, so like we mentioned before as well, the only 2 options you have at your disposal is EPAP or PEEP. And I know PEEP, we tend to use that more on an invasive mechanical ventilator, but we'll call it EPAP on when you're on BiPAP and your FiO2. Now, if you're on higher levels of FiO2, if you're on 50, 60 and more, so 70–80% oxygen, we want to try to get that down as much as we could. So we will tend to give a bit more EPAP. We'll give more EPAP. So it's not uncommon to see an EPAP of 8, 10, and sometimes we can go at 12. But don't forget, the more EPAP you give, it is non-invasive, right? So the more pressures you're giving, the more you're causing of a leak. So we tend not to go higher than that because of the fact that you're going to create more of a leak and more gastric distension potentially as well.
But what is going to be your oxygenation target? What are you going to be monitoring for that, and what is your target that you're going to use to adjust your EPAP or your FiO2?
So we will target saturations on all patients. So
pulse oximetry saturation, that's what you're going to be using.
That's what we're going to be
You're not going to be using the blood gases.
No, because they're not ready. They're not at the ready. They're not there in front of you. So for most patients, we're going to target a saturation of 91 to 94%. If it is a COPDer, we'll target less of a saturation. We'll target 88 to 92 for a COPDer. But for everyone else, for patients, which we end up getting most patients that go on BiPAP or COPD exacerbations,
Okay,
so
so
88 to 92.
getting back to this patient, 67-year-old severe COPD, likely a CO2 retainer, who comes in with an exacerbation and her room air saturation is 85%.
Mhm.
What are we going to be targeting for this patient? This patient itself.
88 to 92
Okay,
saturation.
so really, we're not that far away from our
No.
target saturation. That's the point. She's not likely going to need a lot of
No.
oxygen, nor is she
No.
likely going to need a significant EPAP.
No.
And the questions here, are you able to give nebs with the BiPAP mask on? Yes. So we do have different adapters that we can put in the circuit of the BiPAP to continue the BiPAP therapy and give those much needed bronchodilators. We can give them either in small volume nebulizers, so the actual liquid, the nebs. We can even give MDIs, so the puffer type in the circuit. So it's an adapter that we will just add to the circuit.
Yeah, so I prefer meter dose inhalers myself. And the bottom line is, when you're in this situation, so acute respiratory distress, and on a ventilator or BiPAP machine, a lot of, or the majority of what you're giving, whether it's aerosolized or a meter dose inhaler, is going into the tubing. And there's absolutely no beta receptors in the tubing itself. So it only depends, it's the delivery, just like the oxygenation, it's the amount that's delivered to the alveoli that's important. And when you're in respiratory distress with obstructive situations, you're getting much less delivery than you normally would. So it's not 2 puffs every 4 hours. It's 8 to 10 to 12 puffs, and it may be every 15 minutes. That might be the dose that you're giving. You're going to be, again, looking to make sure that the heart rate isn't going up too high because of excess Ventolin. That would be the toxicity you're worried about. But you're really going to keep giving almost continuously until you see a significant improvement in the work of breathing and the respiratory rate and the tidal volume.
And like you're saying, it might seem like a lot, but if that's what the patient needs, a lot of that is going to be lost in the circuit anyways. So it's better to give.
Yeah, no, one of the most common mistakes that is given is that people are not aggressive enough with their bronchodilators. Okay.
There was another case, there's one more. Or?
Oh yeah, so just mention things about the head of the bed, restriction of oral intake, respiratory depressants.
Yeah, do you want to?
So whenever giving BiPAP, we sit the head of the bed up. We do not deliver BiPAP with someone who's lying down. We sit them up, gravity dependence, diaphragm. We sit them up so they can breathe better. It's easier as well. And yeah, that's what we said. What was the other thing?
Since it's a non-invasive device,
NPO.
we keep the patient's NPO. The air, there is a risk that the air that's pushing into the lungs also goes into the stomach, and we don't want the patient to vomit. So ideally, even an hour before we start therapy, if possible. And during, of course, the whole length while we're on the machine, the patient has to be an NPO.
And I talked about sometimes how we would actually use sedatives such as Precedex or ketamine in a patient who's very agitated in order to get them to cooperate better. But they really have to be used very, very carefully in a monitored situation. If you give just the right amount of sedatives and the patient is less anxious and they're cooperating better with the BiPAP, then you can avoid intubation. And that's an important thing. You're doing this woman, if you avoid intubation in this woman, you're doing her a big, big favor, for sure. Because if she's intubated, it's not going to be an easy road after that, or not likely to be an easy road after that. On the other hand, if you give a little bit too much sedation, so let's on the floor and you just choose Ativan 2 milligrams or something like that. If you obtund them too much, then they're not going to get effective ventilation with the BiPAP. They're not going to be protecting their airway. and therefore they're going to have to be moved on to intubation in that case. So it's really a Goldilocks phenomena, not too much and not too little. Are going to be using sedation, and it really should be done in a very skilled area by skilled nurses and skilled physicians. I don't think there's anything. Does anyone have any other questions about BiPAP right now? We'll wait for a minute. Oh, so well, I'll move on to the other common mistake with BiPAP or high flow nasal cannula is not giving up, persisting too long. So if the patient is put on BiPAP and they have a clear, strong indication for it, which is COPD exacerbation or acute pulmonary edema, those are the two situations where you should really be trying to optimize BiPAP. So the first response to somebody having difficulty tolerating BiPAP should always be better BiPAP. And that's where you have the RTs at the bedside, and they'll do a bunch of troubleshooting. So maybe you can talk about that. So now we have this woman who's got a COPD exacerbation. We're now 1 hour into the whole thing, and she still hasn't, let's say she's exactly the same as she was an hour ago in terms of level of consciousness, respiratory distress, tachycardia, tachypnea, work of breathing. So nothing has changed, okay? And so the physician is going to continue on with the aggressive bronchodilators. If we weren't aggressive, if we will increase the aggressivity, maybe, but she's got the steroids, she's got the antibiotics, she's not in pulmonary edema, we can't give Lasix. So we're talking about, we're asking the RTs about whether there's anything more we can do to optimize the non-invasive ventilatory support. So in this sort of situation, the response to failing non-invasive ventilatory support should always be trying to make sure we're giving an optimized attempt. So what would you do in that situation?
So you're starting to look for other reasons about why this patient is not getting better, or why her CO2 is not going down. And Chantal mentioned before about the obstruction aspect. It's something that's very easily overlooked in BiPAP, and it's something that we tend to not, someone who's as an obstruction. So what we do is we try to position them so that their airway is in sniffing position, and it opens up their airway and they're not as obstructed. Something that, like I said, we tend to neglect to do, but positioning could be very important in these patients.
Or a patient who's slid down in the bed and who's like, oh, you can't see me, but who's hunched over, or who's not sitting properly. Like the head of the bed can be at 45 degrees, but you actually need your patient to be at 45 degrees. Yeah. So repositioning the patient, it has nothing to do with the settings, but it's going to put our patient in a better position to be able to ventilate properly.
Exactly.
Then there's settings, the sensitivities, if you want to mention.
Yeah, that's what. So there's always playing with other settings that we haven't really talked about today, because they're not the main settings on a ventilator or on a BiPAP. But there's other things too, like rise time, things that we could, rise is basically how fast the breath goes into the patient's lungs. It's for comfort. And we try to make the patient as comfortable as possible by playing with those settings. I mean, we went over the more bigger settings like the IPAP. Of course, that's the first thing we're going to play with. We're going to give more IPAP or more ventilation to try to get rid of the CO2. But like I said, there's other things that we have to consider, and patient positioning is something that really easily gets overlooked, and patient comfort for that matter, trying to make the patient as comfortable as we can. Dr. Moss also talked about the cycle as well, how we can make the breath longer. I mean, the patient still controls their inspiratory time, but we could potentially make the breath a bit longer for them, a bit shorter, to make it more comfortable for them on the ventilator. All things that we'll play with.
By playing with those triggers, those sensitivities. Yeah.
So now we're at the 2-hour mark, and you know, as the physician, you have looked over everything you've been doing, and you have optimized everything that you can think of in terms of the bronchodilators and everything else we talked about. We've had multiple discussions with the respiratory therapists. We think that we've given this patient an optimized attempt at non-invasive ventilatory support. We've gone through the troubleshooting from both the medical point of view and from the respiratory therapy BiPAP point of view, and this patient is still getting worse. Okay, so then what should the next step be? So the lessons of the studies that demonstrate that BiPAP is more effective for a COPD exacerbation or acute pulmonary edema. There's a proviso for that, and it's a big proviso, that those patients have to demonstrate signs of significant improvement within 4 hours. Certainly, you'd like to see it within 1 hour, but if you're at the 2 to 4 hour mark and this patient is getting worse, not getting better, and you've really optimized your medical therapy, you've optimized your BiPAP therapy, then the mistake is to persist and not intubate the patient at that point in time. Because what can happen with both BiPAP and high flow nasal cannula is that you can allow the patient to continuously slowly deteriorate over many, many hours, and then it becomes obvious that they need to be intubated, but you've converted I wouldn't call this a low risk intubation, but it's certainly a semi-elective intubation at this point in time, and it's going to be less risk than if we wait for another hour to 2 hours and the patient continues to deteriorate, because your margin of error, the amount of reserve you have at this point in time, is going to be significantly better than it is in 2 or 3 hours. As a corollary to that, so for pure this is for hypercapnic respiratory failure, the same thing holds for hypoxemic respiratory failure. When you're intubating somebody, pre-oxygenation is one of your best friends, and ideally you would like to be able to pre-oxygenate somebody so that they are not going to desaturate for 8 to 10 minutes, meaning that gives you a lot of time to give your plan B and plan C and plan D if you can't intubate on the first attempt. In somebody who's critically ill, that 8 to 10 minutes, even with optimal maximal pre-oxygenation, might only be 1 to 2 minutes, meaning that the amount of reserve you have and the amount of time you have to implement your plan B, C, and D is significantly less. One of the problems with Optiflow or BiPAP with hypoxemic respiratory failure is people keep waiting and waiting as they're dialing up the FiO2 from 50% to 60% to 70% to 80% to 100%. And then you have a patient on 100% FiO2 that there's not likely that you're going to be able to pre-oxygenate any better. You have no other stronger options. And now they're sitting at 85%. To try to intubate that patient, you have basically about 15 to 30 seconds to get the tube in place before they have a hypoxemic associated respiratory arrest. So again, I would say the bottom line for BiPAP or non-invasive ventricular support, including high flow oxygen, these patients, if you put them on them, you should see signs of significant stabilization, if not improvement, by the 1 to 4 hour mark. If you're seeing ongoing deterioration, it's time to cut your losses and move to intubation earlier rather than getting into a crash intubation situation in 3 to 4 hours later. Would you please switch the machine on so we can hear clearly? Oops, we missed that. I think that's all we need to talk about today. If anyone has 1 or 2 other quick questions at the end, they can type them in now. Otherwise, I think we can call it a day. For tomorrow, we're just going to go through a couple of cases in a final skill session. It's really going to be focusing more on the hemodynamic aspects. So we're going to stay, we've done enough respiratory for the last couple of days. So we'll be focusing more on shock and hemodynamics and lactic acidosis. So those would be the chapters I would, or the lectures I think you should be reviewing overnight in preparation for tomorrow. All right, so I'd like to thank both James and Chantal for their efforts in the last couple of days. When you do get into the ICU, you know, the respiratory therapist should be one of your key sources of learning. So I would keep that in mind. All right, everyone can have a good afternoon.